the discussions with us. As you know, Cardiac Specialist Hospital is a national center of excellence, where basically we are into cardiology and interventional services. However, other aspects of internal medicines are also being carried out here. But recently, we added to our services that is being provided in this center, that is open heart surgery, and recently added to the list of services that is being provided at our center here is the open heart surgery. And I'm happy to tell the audience that in the last 2 to 3 weeks, we've been able to carry out 2 successful open heart surgery. We hope that we'll be able to do more in the weeks to come. Also, in the pipelines is the Abuja Perinatal Symposium, rather, that will be coming up on the 15th of May here in Abuja, 2026. And tomorrow, we hope that people will join us as we head these editions of the quarterly Earth Walks tomorrow, starting from the central business districts. We'll walk around and we'll still return back to the same center where we started from. Usually we start by 7 a.m. in the morning. Now, while we wait for more people to join, maybe we should give more people to join. We currently have 27 on the list of people that have joined this webinar. Here with me is Dr. EBUKA OKAFOR, which is a medical officer working at Cardiac Specialist Hospital. My name is Dr. ADEDEJI. I'm a consultant physician and cardiologist. I'll be leading the discussion today. We will wait for more people to join. In the next 5 minutes, we are going to start.
So you're welcome back to this month's health webinar. And today's topic will be pulmonary and venous thromboembolism. We're going with the following outline. All right, so we'll start with an introduction, then we'll look at epidemiology, risk factors, pathophysiology, clinical presentation of venous thromboembolism, look at steps and diagnosis of pulmonary embolism, evaluation and treatments, and then we'll give you our references. So,
okay, by way of introduction, venous thromboembolism is a spectrum of disease that encompasses deep venous thrombosis and pulmonary embolism. There are two different disease entities which are actually spectrum of the same disease. Clot forms in the lower extremities, on the upper extremities, the dislodges and move to a distant pulmonary arteries. And that is basically what pulmonary embolism is. And usually they are formed in the deep veins of the legs of the pelvis. And occasionally you can see them developing on the upper arms. And the incidences of that is more now because of the use of the indwelling venous catheter, interventional devices that are put have increased the occurrence of upper extremities venous thromboembolism. Now, the impact of pulmonary embolism depends actually on the size and the location of the emboli. And it could be fertile, usually due to progressive right-sided ventricular failure. It remains a silent killer just because of its ways of presentation. Usually they are non-specific, and this usually leads to either a mixed or a late diagnosis. It's often been regarded as the most common preventable cause of death in hospitalized patients.
So by way of epidemiology, venous thromboembolism is the third leading cause of cardiovascular death. That's after myocardial infarction and stroke. And an annual estimated incidence of pulmonary embolism is usually between 39 to 115 per 1,000 population. While for DVT, ranges between 53 to 165 per 1,000 population. The incidences are usually higher in older people, in older patients, and in hospitalized patients. So patients who stay in hospital for a more prolonged period of time, and in older people. So the incidences are usually very higher. And approximately 50 to 70% of symptomatic pulmonary embolism patients have a coexisting deep venous thrombosis, while approximately 30% of individuals with DVT have an asymptomatic pulmonary embolism.
Yes, as we all know, it's a disease that usually coexists. And those ones that are coming with symptomatic pulmonary embolism, when you dig further, you see them having a coexisting DVTs, and these have been seen about 50 to 70% of those that have pulmonary embolism usually have a coexisting deep venous thrombosis. For those that have deep venous thrombosis, usually they have this asymptomatic pulmonary embolism in about 30% of cases. The exact prevalence of venous thromboembolism in Nigeria is not known. However, according to Awotedu et al. In Ibadan, he reported a prevalence of 3.8% from the autopsy cases of about 1,583, in which it finds that about 60%, 60 of those patients have pulmonary embolism. Now, the risk factors will be a very strong risk factors. In those are the people that has an odd ratio of more than 10, meaning that they have about 10-fold risk of getting a venous thromboembolism. It could be a moderate risk. People that have 2 to 9 increased fold of developing venous thromboembolisms, and we have a weak risk factors in which the risk is actually less than, the odd ratio is less than 2%. Now, in those ones that have very strong risk factors, usually people that have fractures of the lower limbs, patients that are hospitalized for heart failure in the last 3 months, patients that have hip or knee fracture, or hip or knee replacement, they are major risk factors for venous thromboembolism. What it means that if you have such a patient, you must prophylactically anticoagulate them to prevent the risk of developing venous thromboembolisms. Now we have the major risk factors. Patients that are on central lines, patient that has indwelling catheter, heart failure patients, patients that are on hormonal therapy, women that are taking oral contraceptive pills. Now, the risk of developing venous thromboembolism from oral contraceptive pills is around 2 to 9 increased risk. However, in some patients that has deficiencies of factor V leadings, in the presence of factor V leadings, the use of oral contraceptive pills in women increases the risk by more than 50%. Other risk factors for development are here. Low risk like diabetes mellitus, systemic hypertension. However, if they have multitude of these weak risk factors, it can actually increase their risk of developing venous thromboembolisms. Okay, what are the pathophysiology of the pathophysiology of venous thromboembolisms?
So before we continue, I just wanted to highlight something. There's a chat box there, so please don't forget, if you have questions, have any comments to make, just drop them in the chat box and we'll be able to see it. Okay. All right. So going on with pathophysiology of venous thromboembolism, it's usually from what we call the virtuous triad. It's like they call it the recipe for thrombosis. So what happens is that it comprises of 3 components, and one of them is stasis. So when there's an immobility, or in patients who are over 40 years old, those who have had heart failure, spinal injury, something that's caused them to stay immobilized for a prolonged period of time, that could lead to stasis. All right. And then the second factor is also hypercoagulability. So in certain patients, maybe those with cancer, pregnancy, those with certain conditions like thrombophilia, use of estrogen, maybe in postmenopausal women, this can actually increase their hypercoagulability. So this increases the risk of VTE. And then also, lastly, it's endothelial damage. So this can be seen in people who have had some form of trauma, who have had some surgeries or central line inserted. So all these 3 components make up the virtuous triad, which actually serves as the major pathophysiology of venous thromboembolism.
Yes, the main factor that are implicated in the pathophysiology, as I said, is this triad of stasis of blood in the lower extremities. Don't forget that with the stasis, at that point, they are prone to hypoxia, there could be endothelial injury, platelet will adhere. Once platelet adhere to that place, there will be changes in conformations, there are release of factors that draws other platelet to the site. Phosphocyanin also is produced that allow for the additions of the activate clotting factors, additions of clotting factors, thrombus are formed. When the thrombus are formed, the thrombin rather are formed, which converts fibrinogen to fibrins, and this led to a cascade of processes that leads to the formation of thrombus. Usually they are localized at the valves. And that's the reason why in those patients that have deep venous thrombosis that are not properly addressed, at the long run, they can develop post-thrombotic syndrome. Now, when they are formed in the lower extremities, if you look at this picture very well. You can see thrombus that are formed in the valves of the deep veins of the legs. They will dislodge and travel to a distant side through the inferior vena cava. They go to the right ventricle, the right side of the heart. From there, passing through the pulmonary artery, from where they lodges in any of the branches of the pulmonary artery that led to the development of clinical symptoms of pulmonary embolism. Now, once these are formed, there is a buildup of pressure in the pulmonary arteries. That artery puts a strain on the right side of the heart. With the strain on the right side of the heart, there is distensions, there is strains on the right ventricular wall. The dilatations now result in they activate the neurohormonal pathways. The dilatation also results in the reductions in right ventricular stroke volumes, as the reductions in left ventricular preloads. Cardiac output becomes low. Because of that, there's reductions in pulmonary perfusions and oxygen delivery to different sites in the body. Now, because of the distension also, there could be microischemia in the right ventricular wall, and it will actually lead to, at the long run, lead to right ventricular infarction that led to release of biomarkers, as we've seen as we go on. With the thrombus that lodges in the pulmonary artery, there's usually a mismatch between the amount of oxygen flow to the body and how it passes through that place, resulting in pulmonary atrioventricular mismatch. And subsequently, the patient can develop hypoxia. Now, as a way of presentations, it could just be asymptomatic, meaning that they are peak incidentally for other reasons, while being evaluated for other diseases. They could present acutely, and there could be a chronic complication, those ones that are missed at the long run. Now, what are the ways in which we evaluate a patient with suspected PE? Either we want to confirm or you want to exclude pulmonary embolism. These are the 6 steps that summarizes how to evaluate a patient with pulmonary embolism. Usually, they will come typically, in those ones that come acutely, with difficulty in breathing, unexplained difficulty in breathing. Some of them can have hypoxia, some can have chest pain. And when you are seeing somebody that has an unexplained difficulty in breathing, whether they are hypoxic or not, and when you examine the chest, you are not finding something remarkable, you should start thinking about the possibility of pulmonary embolism. Now, they also present, depending on the extent and the size of the infarct, they could present with hemodynamic compromise. Now, once they come with hemodynamic compromise, there will be a change to the dynamics in the flow of evaluation of such a patient. If a patient is coming with difficulty in breathing, or when you see come with unilateral leg swelling, there is poetic chest pain, but when you check, the hemodynamic parameters are still very stable. BP is still within range. That means you can follow this level approach in the evaluation of patients. But in those patients that have accompanying hemodynamic compromise, you will skip all these steps and come straight away to step 5 with your bedside echo. You want to actually look at the right side of the heart. In the patient that I think has a hemodynamic compromise, you do your echo. There is right ventricular problem, right ventricular, yes, it increases your ADEDEJI suspicion, and you commence your treatment and plan to take in the patient for CT pulmonary angiography. But in those ones that has the vitals are okay, the next thing to do in such a patient is to assess the risk of development of pulmonary embolism. Let me follow this. Okay, as you all know, I said it's usually the main thing is difficulty in breathing, non-specific, making it to be a masquerader of so many disease entities. Now, with this, your ADEDEJI suspicion must be very, very high. Unexplained dyspnea, some can come with lateral leg swelling. You start thinking, is it pulmonary embolism or the other possible differentials as we are going to see as we go on. Now, the other thing that patient can present with is chest pain. Now, the characteristic of the chest pain depends on the location of the emboli itself. If it's distally, patient can come with poetic chest pain. If it's central, these are the ones that come with what look like an angina chest pain. Especially if you have an accompanying right ventricular ischemia. Some of them can come with hemoptysis because of pulmonary infarction. In those one that has hemodynamic compromise, typically they can present with syncope or pre-syncopes. These are what we are going to see in the patient that has a massive pulmonary embolism. Now, what defines an hemodynamic instability in pulmonary embolism? Patients that presented with a cardiac arrest leading a cardiopulmonary resuscitation, patient that has systolic blood pressure less than 90 minutes of mercury that persisted for more than 15 minutes or requires a vasopressor to achieve a systolic blood pressure of more than 90 despite an adequate filling status, and features of end organ hyperperfusion. Patient come with altered sensorium, reduction in urinary output, cold extremities. Those are the way the patient can present, or they have a transient or a persistent hypertension. These are the features that when you see a patient with a suspected pulmonary embolism, you should know that these are features of a massive pulmonary embolism. These are high-risk patients. On examination,
so at presentation, some of the things you can see include unilateral leg swelling, and when you examine, you're likely to get a differential want, calf tenderness, and this can be seen in at least 75% of patients who present with venous thromboembolism, and then they will also appear tachypneic as well too. There's going to be hypoxemia, but it's not as frequent. At least less than 40% can have a normal arterial oxygen saturation, and then they come also. They could be tachycardic as well too. About 24% of them will present this way, and then pulmonary rheos can be seen in about 18% of patients with venous thromboembolism, and then there's also a decreased breath sound, and there's accentuated pulmonary component of the second heart sound that allow P2 to see about 15% of them. And then if you check for the JVP, it should be distended, at least in about 14% of patients who present with this condition.
Now, as a backup to what you said, we have currently in cardio care, we have a 68-year-old woman, basically just present with difficulty in breathing. It's obvious it's tachypneic, but when we examine the chest, there's nothing remarkable. But he has an associated pulmonary component of second heart sound. West score was 5. We did a CTPA. Because of the West score that was more than 4, it came out of pulmonary embolism. Well, what this means is that if you see an unexplained difficulty in breathing, patient is tachypneic, but nothing remarkable on the chest when you examine to explain this difficulty in breathing that the patient is having. You must have an high index of suspicions of a possible pulmonary embolism. Now, as step 2 to the evaluations of a patient with suspected pulmonary embolism, the first thing is the clinical presentation. The second stage, or the step 2, is to assess their pre-test probability risk of actually having a pulmonary embolism. These are the scores that can be used. Commonly, we use West score, but they are revised Jennifer clinical position rule for pulmonary embolism. There's also pulmonary embolism rule-like criteria, which we'll be discussing subsequently. Now, usually once you see a patient, symptom-wise, unexplained difficulty in breathing, the next thing you want to assess the risk. Commonly, we use West score. A patient that have a clinical signs of deep venous thrombosis, if it's present, the score is +3. There's no alternative diagnosis to what we are seeing rather than pulmonary embolism, is a score of 3. Patient is tachycardic with a heart rate of up to 100 is 1.5. Patient has been immobile for the last 3 days, probably post-surgery of other medical illness, or he had surgery in the last 4 weeks. The score is also 1.5. Previous DVT or pulmonary embolism is score of 1.5. Patient that comes with hemoptysis, the score is 1. Malignancy, whether it's on treatment now or has been treated previously in the last 6 months on palliative treatment, there's also a score of 1. When you put all this together and you have a score that is less than 4, that means pulmonary embolism is unlikely. But if you have a score that is up to 4, meaning that pulmonary embolism is likely. In such instance, in those one that has a score of less than 4, you want to further risk stratify them using biomarkers. Here, commonly we use D-dimer, a D-dimer, a negative D-dimer that is less than 500 microgram per liter exclude the possibilities of pulmonary embolism. Meaning you have to look for alternative explanation for the difficulty in reading that the patient is having. Yes, but if it's positive, it increases your suspicion because there are other causes of elevated D-dimers. Sepsis, previous surgery, trauma, myocardial infarction, peripheral arterial disease, acute ischemia, sepsis, they are all causes of elevated D-dimer. When you see that, you go ahead to do your computer tomography, pulmonary angiography to confirm that the patient actually has pulmonary embolism. Yes, now, just to be sure that we were able to pick something away, we assess this later on. Now, the other probability scoring system, which is the revised Jennifer, has almost similar parameters, but just a slight difference. When you look at the previous pulmonary embolism in Jennifer, it's also present in West score, but the score, however, differs. If you have a previous score, these are another score that can be used. Previous PE with a score of, we are using old original version. Simplified version is 1. Heart rate of 75 to 100 is also 1. If it's more than 95 is 2. Surgery or fracture in the past month is also 1. Hemoptysis is 1. Other criteria is all 1. In a patient, we are using 3-level score. A patient that has a score of 0 to 1 is low risk. Patient that has 2 to 4 is intermediate risk, while those one that has score of 5 and above are high risk. If you have that, these are the patients you go ahead to confirm your suspicion based on this risk score. If you are using a 2-level score, a score of 0 to 2 is unlikely, but a score of greater than or equal to 3, meaning that 4 and above increase your risk of pulmonary embolism, and you have to go ahead and confirm this. Now, in those patients that you have assessed their risk, the risk is low risk, but you still have the suspicion that they have pulmonary embolism, and that's when the pulmonary embolism rule-like criteria was developed. The aim of this is to make sure that we don't request for high-valuing investigations that will now, at the long run, turn out to be negative or P. These are actually negative criteria that once they are present, there are about 8 parameters here. Aim is to make sure when these are criteria that they shows that patients are unlikely to develop a pulmonary embolism. If it is present, it's 0. If it is not, it's 1. For example, age less than 50. If the patient is less than 50, the score there is 0. But it's more than 50, it has a score of 1. Heart rate that is less than 100, the score is 0. But if it's greater than 100, that means the score is 1. Oxygen saturation at presentations is more than 94. The score is 0. But if it's less than, the score is what? Is 1. No unilateral leg swelling. That means patient has no unilateral leg swelling. The score is 0. But if you have unilateral leg swelling, the score is 1. No hemoptysis is 0. Hemoptysis make it 1. No surgery in the last 4 weeks, that make it 0. But if there is surgery, make it score 1. Yes, these are the criteria that you use in ruling out in those one that has low risk of pulmonary embolism. Anybody that has a score of 0, the probability of pulmonary embolism is almost 0. Now, to assess those risk classifications that are discussed above, this is a patient that we manage in cardio care. It's a referred case from, I want us to assess the risk score in a patient that was suspected as pulmonary embolism. A question will follow. We expect people to respond and put their answers in the chat box. This is a 41-year-old female. She was referred from a peripheral hospital. She presented with sudden onset of difficulty in breathing and chest discomfort of about 12 hours. That was said to be associated with sweating and non-productive cough. However, there was no hemoptysis, no fever, and the discomfort does not relate to any part of the body. The woman was not known to have hypertension or diabetics, no previous history of pulmonary embolism or DVT. She neither smoked or take alcohol. However, had surgery, which is myomectomy, in the last 4 days for symptomatic uterine fibroid. She's not on oral contraceptive pills. On examinations, she was in respiratory distress. She's tachycardic with pulse rate of 102 with good volume, BP of 136/76. JP was not raised. Heart was just 1 and 2 with a loud P2. She's tachypneic with respiratory of 30, and the saturation on here was 86% on presentation with fine crepitations at the basis. Now, looking at this criteria, looking at this information rather, assessing the risk score will be the next attempt in actually confirming the risk of pulmonary embolism in this patient. Now, the question that follows is, what is the likely risk West score for this patient? West score for the patient. This is a woman with sudden onset difficulty in breathing of about 12 hours with no cardiovascular risk factors. The chest pain does not radiate to any part of the body. However, had surgery in the last 4 days, which is a risk factor for development of PE. But on examinations, she was tachypneic, she was tachycardic, BP was normal, saturation was about 86%. What's the likely risk score of this patient? Please, audience, any attempts?
You can drop the answer in the chat box.
Please, you can drop the answer in the chat box. Okay, if you look at what we said about the West score, that when there is clinical signs and symptoms of the patient developing deep venous thrombosis, we said he has a score of +3. If we have no alternative explanation for the patient new onset difficulty in breathing other than pulmonary embolism, the score is 3. For this patient, he has a score of 3 already. He had myomectomy about 4 days ago, which is a risk factor. Now he's tachycardic, which is a score of 1.5. And he has had surgery in the last 4 weeks. This one had surgery in the last 4 days, which is a score of also 1.5. When you look at this, what is the likely West score for this patient? Okay, getting the correct answers there, we also determine the next approach in the evaluation of this patient. Now, if you look at this, the West score of this patient is 6. That means the next approach is to do a confirmatory test, which is CT pulmonary angiography. And this is what I said. PE likely is no alternative diagnosis is 3. Heart rate of 100 is 1.5. Immobile for the last 3 days, and even had surgery in the last 4 days is also 1.5. Now, if you add this together, the total score is 6, meaning that the PE is likely. The next thing is to do what? You do your CT PA, which is what was done in this patient. You see the outcome of the investigation as we proceed. Now, the next step, which is step 3 and 4 matched together, is the biomarkers. Now, we said in those one that has a risk score that is low risk for PE, you go ahead to further risk stratify them. In this scenario, you do your D dimer, though it's highly sensitive, but specificity is low because of other causes of elevated D dimers. Elevated D dimer in the settings of PE shows a breakdown of form clots, which is a product of fibrin degenerations, meaning that if it's elevated in those one that has a risk, a low risk, it increases the suspicions and you go further to do your CT pulmonary angiography. But if the D-dimer is normal, meaning that the value is far less than 500 microgram per liter, this excludes PE, because if there is no thrombus form, D-dimer won't be elevated. That means this one has excluded a PE. But if it's elevated, that means you will now go further to do your CT pulmonary angiography. Now, for age that are more than 50 and above, we do an age-adjusted D-dimer in which the age of the patient multiplied by 10, in those ones that are more than 50, for better accuracy. Now, the next thing that we can do as per the biomarkers is the troponin and brain natriuretic peptide. Troponin elevation in the settings of PE gives you an idea about the right ventricular infarctions, which is a marker of poor prognosis, poor clinical outcome, and clinical deterioration when patient is on hospital admissions. Brain natriuretic peptide is a reflections on the stretch on the right ventricle, and is also a poor marker in a patient coming with pulmonary embolism. It increases the risk of PE associated death. Now, for ECG, the commonest findings that you see is sinus tachycardia. Other things that you see on ECGs are features of right ventricular strains, which could be right axis elevations, right bundle branch blocks. You can see T-wave inversion that is suggestive of right ventricular strain. Rarely you can see the S1Q3T3, which is the most specific, but it's however rare. It's rarely seen in less than 25% of patients that are presented with pulmonary embolism.
So we spoke about imaging earlier, and then we said earlier that the gold standard imaging for making a diagnosis of pulmonary embolism is the CTPA, that's the CT pulmonary angiography. But also we also employ the transthoracic echo as well too. So the echo is usually done bedside, and it's for patients who are critical and very unstable. So we use it to assess the right ventricular function. And some of the findings you can see are an enlarged right ventricle, and then right ventricle, left ventricular ratio greater than 1. Then the Marconnell sign as well too, whereby there's actually like an akinesia of the right ventricular free wall, but at the apex, it actually contracts normally. So that's the Marconnell sign. Then there's this sort of 60/60 sign as well. So some of the things you see on echo when you do like a bedside echo for this patient. And like I said, it's for more unstable patients. While the CTPA is the gold standard investigation, it is the preferred initial imaging for stable patients. And this will now look out for the feeding defects in the pulmonary arteries. But it's usually contraindicated in patients who have like a renal issue, those who have had severe contrast allergy, or in pregnancy as well, because they require the use of a contrast like a dye to outline the pulmonary arteries. So it's contraindicated with those with renal failure, and then with severe contrast allergy, and as well as in pregnancy as well too.
As what was mentioned earlier, in the step-ladder approach to the evaluation of patients with suspected PE, you will see that echo is like step 5. But in those ones that are coming with hemodynamic compromise, that step can be skipped. If somebody is coming with hemodynamic compromise, meaning that it's saturating, you check the BP, it's less than 90/60. Now, the next thing you do is to do your bedside transthoracic echo. But in the patient that has hemodynamic compromise, you expect that the right ventricular side will be dilated. But if you do your echo, if it's dilated, fine, it confirms your suspicion. You start your treatment, optimize the patient, stabilize the patient, and you plan to do your CT pulmonary angio to confirm the diagnosis. But those ones that you are thinking has an hemodynamic compromise, patient has an hemodynamic compromise, and the echo now came out, the right side now came out to be normal, meaning that you have to start thinking about other possible explanations for the cause of the hemodynamic compromise. Now, as we said earlier, the CTP is the gold standard for confirmation of pulmonary embolism. However, there could be a contraindication to this, renal failure, because the contrasts that are ingested to do the test are usually excreted through the kidney. You don't want to worsen the baseline clinical characteristics of the patient. A patient that have a contrast allergy, a pregnancy because of the risk to the fetus. Now, when you do your bedside echo, these are the likely findings that you are going to see. Naturally, the left side of the heart constitutes about 2/3 of the heart, while the right side constitutes about 1/3 of the heart. But because of the strains on the right side, the reverse is the case. The right ventricular will be dilated when you compare it to the left ventricle, and usually the ratio will be more than 1, with right ventricular hypokinesia, with EBUKA and the basal sparing of the right ventricular, which is popularly regarded as the McConnell sign. Now, because of the prior effect, you can see a flattening interventricular septum because of the prior effect on the right side. These are some of those things that you are going to see. The inferior vena cava will also be dilated because of the back flow effect. Now, when you do your Doppler study, the pulmonary acceleration time will usually be less than 60 milliseconds, and you can see a mid-systolic notching of the Doppler tracing, and the peak velocity for the tricuspid valve usually they are less than 60, which usually regarded as a 60-60 sign. When you have that 60-60 sign, usually a pointer to an acute pulmonary embolism. But by the time you are seeing a T tricuspid regurgitation grade that is more than 60, you must be thinking of the possible chronic pulmonary embolism that you are dealing with. Some of them they have the tricuspid regurgitations, systolic functions of the right will also be affected, evidenced by the low TAPC that you are going to see. Now, when you look at this CT, which is a contrast tomograph pulmonary angiography of a patient, you can see a filling defect at the central area of the pulmonary artery, involving the bifurcations of the right and the left. This usually looks like this is more of a saddle embolus that this patient has, because it's picking on the bifurcation region of the pulmonary drums. When you look at the other image, you can see that the right side is occupying more than 65 to 70% of the heart chambers. It tells you the level of the pressure buildup on the right side of the heart, which are all in keeping with the diagnosis of pulmonary embolism. Now, in those ones that are coming with a unilateral leg swelling, in order to confirm that it's PE, or to exclude other alternative explanation for unilateral leg swelling like cellulitis, popliteal cysts, lymphomas that could develop in the legs, usually we use a lower limb Doppler ultrasonography. And the give out when we are doing the Doppler ultrasonography is that the vein will be incompressible. Normally they are compressible, but when you do your Doppler and it's incompressible, it gives you a good idea that this patient has a thrombus in the lower extremities. Now, the Doppler ultrasonography will also be very useful in those ones that has a contraindications to CT pulmonary angiography, or they have a negative CT pulmonary angiography test, but your suspicion is still very high. You can go ahead and do your Doppler, and if you pick something, you treat as a venous thromboembolism in that instance. Now, chest X-ray, yes, commonly done, is better helpful to establish other causes of dyspnea and chest pain. When present, usually they are non-specific. Prior effusion can be explained by other disease, chest infections, and all those. Atelectasia consolidations are some of the non-specific findings that you can see on chest X-ray. Though uncommonly see when present, you can see the Westermarck sign, which is usually the region of, you see either a local or regional oligemia in the patient, Hampton arms, which is more of a wedge-shaped infarct that you see on the pleura. Usually the base is on the pleura, while the apex will be pointing towards the lung tissues. The pallor signs is basically the dilatations of the inferior part of the pulmonary artery. Usually, chest X-ray findings may not be specific. Better to rule out other causes of difficulty in breathing and chest X-ray. Now, other baseline investigation that you want to do in preparation for anticoagulations is your liver function test. Don't forget that metabolism of some of these our newer drugs occurs in the liver. Liver that is deranged or diseased, you have to look for alternative anticoagulant that you want to use because it can increase the risk of bleeding in such a patient. Patient that have liver disease may not be producing enough clotting profile, worsen the risk of bleeding in them. Full blood count, they can develop thrombocytopenia. Apparently, this thrombocytopenia is there. You want to be sure of their baseline clotting profile and the NRR. I also want to be sure of their kidney function test before you commence the treatment. This is just a recap to the system in the evaluations, either to confirm or exclude the diagnosis of pulmonary embolism. As we said earlier, clinical presentations is the first thing. The clinical presentation guides you to determine whether these are low-risk patients, intermediate or high-risk patients. Low-risk patients, you follow the step-ladder rise, which is you do a risk score to determine whether it's PE or not. You do your biomarkers, ECGs, and you go ahead to do your echo and confirm with CT pulmonary angio. But in high-risk patients with hemodynamic compromise, step 5 straight, do your bedside echo, assess for right ventricular dysfunction. If present, you go ahead and do your CTPA. Don't forget that the presentation in the patients are typically chest pain and difficulty in breathing. There are other reasons for that, and that's why the differential diagnosis must be at your minds. Other things like acute pulmonary syndrome, heart failure, sepsis, and pneumonia are the things that you consider in the evaluation and management of this patient. Now, this is also a good chart to recap what has been discussed. Is your patient hemodynamically unstable, meaning that you are suspecting PE, he has a low BP persisting for more than 15 minutes or require a vasopressor for it to be more than 90 in the presence of an adequate filling status and end organ damage, patient with cardiopulmonary arrest, or patient that has a transient or persistent or transient hypotension. Now, if he has this hemodynamic instability, you follow this particular is yes. If it's yes, the immediate bedside echo will be done. If right ventricular dysfunction, as I said, you go ahead to do your CTPA and you treat as high-risk pulmonary embolism, which is an immediate thrombolysis. This which helps to dissolve the clots, improve oxygenation, improve right ventricular functions, and hemodynamics in such a patient. But if patient has a PE, no hemodynamic compromise, that means the patient is stable. You do your risk assessment into either a low risk or high risk intermediate risk patient. You do your D-dimer. If it's negative, that means PE is unlikely. If it's positive, you go ahead and do your CTPA. And you anticoagulate. PE with hemodynamic stability, first line treatment is anticoagulations. Now, how do we risk stratify a patient? Risk stratification is just to determine whether your patient is high risk, intermediate or low risk, because this one determines your approach to management. Suspected PE, who is stable, blood pressure is fine, the right ventricular function is normal, biomarkers is okay, and the PESI score is 1 and 2. What you do is that these are low risk. These are the patients just commence your anticoagulant. Now, the intermediate risk are patients that are suspecting PE, and but they have the signs of right ventricular dysfunctions, but it may be accompanied by a myocardial injury markers or not. Right ventricular dysfunctions with evidence of markers of biomarker injury, especially troponins. Those are patients that are the intermediate high risk patients because their risk of deterioration while on admission is very high. They have right ventricular dysfunctions and they have elevated troponin. These are high risk. Right ventricular dysfunctions, troponin is normal. These are low risk patients. In those ones that are intermediate high risk, even though you have started the usual anticoagulation in them, your eye must be on them because they can deteriorate while you are in the ward. The risk of in-hospital mortality is very, very high. If for any evidence of a drop in a baseline BP, you must consider thrombolysis in this patient. Either you do a systemic thrombolysis or catheter-directed thrombolysis in those ones that have a high risk of bleeding. But in those ones that has intermediate low risk, meaning that they have right ventricular dysfunctions, troponin was normal, continue anticoagulations and treat as such. But in those with high risk, these are the patients that on the first line, you want to thrombolize them to dissolve the clots. Now, in assessing those risk of patients of dying within the first 30 days of hospital admissions, that's what the pulmonary severity index score is all about, the PESI score. In the patients following this, about eight criteria here, in a patient that have a score which was less than 66, the risk of death is less than 1%. But if the PESI score is between 60 and 85, those are one that risk of death is around 2.5%. The higher the class, the higher risk of death within the first 30 days of hospital admissions. And the risk can be as high as 27% in a patient that have a PESI score of class 5. Now, how do we treat these patients? How do we treat them? Go one, and those ones that are hemodynamically unstable is a thrombolytic therapy. And this is aimed to dissolve the clots, improve the right ventricular functions, pulmonary perfusions and hemodynamics. The go-to in those ones that are hemodynamically stable is to anticoagulate, treat the current and prevent recurrence. And 3, you treat complications in those ones that presented late or the diagnosis was missed at the first instance. Now, for those ones that are coming as high risk, as part of what we are going to do, you want to do a food challenge of less than 500 mils because, before now we said there is a pressure build-up on the right side, the ventricles are dilated, cardiac outputs are low because of the poor right ventricular systolic functions. Now, if you overload more than 500, you give fluid that's more than 500, it can worsen that ventricular dysfunction, worsen the cardiac outputs, and worsen the clinical outcomes. And those ones that have done that free challenge and you are not getting what you want, you can commend your vasopressor to assist in improvement of the blood pressure. But don't forget that the goal is the perfusion therapy in those ones that are coming with hemodynamic compromise. And this could be systemic thrombolysis using arteplase or tenetoplase, or in those ones that has high risk of bleeding, you consider catheter-directed thrombolysis, in which in the cath lab, which is what we do very well here in cardio care, you take in your catheter through the femoral artery and go straight to your pulmonary roots, and you try to give usually 1/5 of the expected dose to be given over 18 hours in the patient. Why that? It continues to dissolve the clots that are formed pulmonary, and you will see that clinical improvement. Saturation will improve, the requireless oxygen, hemodynamic will improve in those ones that have been managed, and they are usually discharged within a week of admissions. Now, the other mode of treatment is the surgical approach. It could either be endovascular or embolectomy, in which you take in a catheter, usually a narrow catheter, you take in it and you suck out the clots in such a patient. Now, for the treatment of intermediate and low risk patients, those are patients that are stable. First line is anticoagulation, which must be commenced immediately. Current guidelines favors the newer anticoagulants, the apixaban, rivaroxaban, are preferred over the conventional vitamin K antagonist, which is warfarin. The use of lower molecular weight heparins also can be used in initial phase of treatment of this patient. But don't forget that there are contraindications to the popular NOACs that we use now. Patients with renal impairment, patients that are pregnant, and phospholipid syndrome, some of those contraindications to use of NOAC, in which we have to consider other alternatives in the management of your patient. However, in patients that have thrombophilia, these are patients with factor Latin 5 deficiency, protein C and protein deficiency, antiphospholipid syndromes. These are patients that you treat on a long-time basis. It's a lifetime treatment in such a patient. But the other people that don't have history of recurrent pulmonary embolism or DVT, usually treatment is 3 to 6 months, depending on the peculiarity of the patient. Now, these are the usual drugs that are used in the clinical, in our centers there. The newer and oral anticoagulants are more preferred. Commonly, we use the Varoxaban, usually which we start with a loading dose of 15 milligrams, morning and night, for the first 21 days, and now continue at 20 milligrams daily for the next six months. Other ones that can be used are Pizaban, which is commonly available. We rarely use Abigatran, but it's also available. Now, these are the dose of lower molecular weight heparin. Usually, we give at 1 milligram per kg, given every 12 hours, or you use a single daily dose of 1.5 milligram per kg in our patient. Other one that can be used that is Zaparin and the Taparin. That's what can be used. Now, as I mentioned earlier, that intermediate risk of pulmonary embolism, first line thing is still anticoagulation. However, you must be on the lookout. Right ventricular dysfunction initially, some of them, while they are presenting, they can have elevated biomarkers, elevated troponin, elevated brain natriuretic peptide, but their BP is still okay. 120, 70, 120, 80, 130 over 80. But you must be on the lookout because they are associated with risk of deterioration while on admission, risk of in-hospital death, meaning that for a slight drop in that BP, 20-10 drops on the BP, you must consider thrombolysis in such a patient, especially if they are high risk PE. If it's intermediate low risk, meaning that right ventricular dysfunction only, troponin was normal, you continue anticoagulations and discharge your patient to see you in the clinic. But with intermediate high risk, right ventricular dysfunctions, elevated cardiac troponin, you must consider thrombolysis, either systemic or catheter-directed thrombolysis, depending on the risk of the patient.
So for prophylaxis now for venous thromboembolism, this is something we offer patients, and it's something we do here, even in cardio care. All our patients who are going to be on admission for more than 48 hours, be on thromboprophylaxis for VTE, and especially those with underlying medical comorbidities who have had like a recent pelvic surgery, like maybe a hip replacement or something. So we place them on prophylaxis for VTE. And there are two types, two ways we could do that, either pharmacological or mechanical, although here we mostly employ pharmacological means. And also in high-risk populations, such as those who have had like a hip or knee replacement or combination therapy could be considered. And we tend to extend this prophylaxis for some people for up to 28 to 35 days. In some people, some particular patients, like those who have had a hip fracture or post-hip replacement surgery. And so for the long-term sequelae of the venous thromboembolism is that you can have a recurrence of this condition. And then also you could also have a post-thrombotic syndrome as well too. And then it could be venous ulceration. And then also, lastly, you could have a chronic thromboembolic pulmonary hypertension, which you call CTEPH.
Now, part of the long-term complications of pulmonary or venous thromboembolism is that it could be recurrent, even despite treatment. And these are the people that you consider genetic factors as a cause of the recurrent venous thromboembolisms, the thrombophilias. When somebody is having a recurrent venous thromboembolism, you must screen them for these factors: factor C, factor S deficiency, factor Leydens, antiphospholipid syndrome. They must be screened to be sure that the cause of this recurrent thing is not from the genetic causes. Now, for post-thrombotic syndrome, these are syndromes that develop as a result of the destructions of the valves of the deep veins of the lower extremities, usually from a massive deep venous thrombosis, or a patient that inadequately treated. Now they develop that destruction. Because of that, there is incompetence, and they presented with refractory unilateral leg swelling as a result of the destructions of the valves of the lower extremities. Because of that, they tend to have stasis of fluid around that area. They develop venous aspirations because of the stasis of fluids on that leg. Now, the other complication that will arise is when the pulmonary embolism was not discovered and is now lasting more than 6 months. This could be very, very disturbing. Usually you see they have a pulmonary pressure of more than 20 millimeters of mercury. They come with this worrisome, recalcitrant, bilateral leg swellings that is, they tend to have persistent dyspnea, right ventricular failure, and this is a very terrible experience if you have seen a patient that has developed this because of the initial means of patient was not properly managed. In such a scenario, treatment is lifelong. The first line of choice in their management is actually pulmonary endarterectomy in those ones that are operables, or you do a balloon pulmonary angioplasty for those ones that are inoperable. Now, before we go to the case series, so far I don't know if there's anybody that has a clarifications as per what has been discussed so far. We try to look at what is venous thromboembolism. We look at the epidemiology, both internationally in our environment. We also look at the risk factors that ranges from strong risk factors to moderate and weak risk factors. We consider the pathophysiology of development of venous thromboembolism in these patients. We look at the ways or the step in which patients that you are suspecting as a pulmonary embolism can be evaluated. We highlighted a 6-step approach to the evaluations to confirm or to exclude pulmonary embolism in such a patient. We look at the ways in which this patient can be stratified into either a low risk, intermediate, and a high risk patient, which as well determine how we are going to manage these patients. We talk about the treatment approach in terms of thrombolysis for those ones that has an high risk pulmonary embolism based on their hemodynamic parameters. We talk about the rules of anticoagulations in the treatment of those that has a low and intermediate risk of pulmonary embolisms. We further stratify those ones that has intermediate risk into those ones that are intermediate low risk, meaning that the right ventricular dysfunction, however, cardiac troponin was normal. We also discuss about the intermediate high risk patients that have had right ventricular dysfunctions and they have an elevated troponin. Even though you started with the usual anticoagulations, your index of deterioration in this patient was very high, and if for any reasons there is a signs of hemodynamic compromise, even with a slight drops in their BP, please you consider the use of rescue thrombolytic agents in this patient, which will either be a systemic one or you do a catheter-directed thrombolysis in such a patient. Those are what we've discussed so far in the last couple of minutes. I don't know if anybody has a question before we now go to look at how far we've been able to pick up along in our discussions. We start with this case 2. I don't know if anybody has a questions. Well, I've not seen anything on the chat box since morning. The Q&A, let me see if there's anything in the Q&A. Okay, Q&A, okay. Okay, sorry, we didn't know that something was dropped on the KRA. He said, why is it more in older people? Okay, the reason why it's more in older people, if you look at the triads that lead to the development of the thrombus, we talk about endothelial dysfunctions. We talk about hypercoagulability. We also talk about stasis from immobilities. Elderly people have fragile vessels, the endotheliums, the integrity is not as strong as it used to be, meaning they are easily prone to tear, additions of platelets, clotting activations, and this of thrombus formation. And that's the reason why it's commoner in them. The same reason goes for people that are admitted, probably from sepsis or any ongoing diseases. They are immobile. Being immobile causes stasis of blood, make the walls to be prone to injuries, additions, and clot form at the long run. And that's the reason why it is more commoner in those ones that are in the older age group. The second patient here, which is Emmanuel, okay, it's just a number. Not a question, just to note that Dr. Emeka Okafor is not audible enough, sir. Okay, sorry for that. Sorry for that. Okay, I think. Okay, now okay. The first case, the worst score was actually 6, not 3. If you look at that patient, is new onset difficulty in breathing. That we are thinking from pulmonary embolism, meaning that there is no alternative diagnosis that we are thinking of now, other than P, that's a score of 3. Is a woman that had surgery in the last 4 days. Don't forget that somebody that had a surgery will both be on bed for the last 4 days from the surgery. Also, the surgery has had from the criteria, anybody that has surgery in the last 4 weeks is a score of 1.5, and is tachycardic, which is also a score of 1.5. If you look at that, in addition, everybody is 6. Everything had sum together is 6. Now, let's go to case 2. Is this same patient referred from a peripheral hospital, 41-year-old female, sudden onset difficulty in breathing, and chest discomfort of about 12 hours, said to be associated with sweating and a non-productive cough. The chest pain was not radiated to any part of the body. Is not known to have any cardiovascular risk factor. She neither smoke or take alcohol. Had mammectomy 4 days ago for symptomatic uterine fibroid. Is not on oral contraceptive. Is tachycardic. BP was normal at presentation. BP was not raised. Heart sound was 1st and 2 with a loud P2. The only thing that give out the woman that have in the world currently was just a loud P2 that we get in the woman. Respiratory was 30, and saturation was 86% with fine crackles at the lung basis. Looking at this, a question will now follow. Okay, these are the laboratory parameters for the patient. D-dimer was 10. From the full blood count, he has absolute leukocytosis. The renal function cell was fine. The NT-proBNP was 1,508 picogram per ml, which is elevated. Troponin was 1.2, which is also elevated. RNR was fine. She did a Doppler ultrasound that was negative of deep vein thrombosis. On the CTPA, he has a central filling defect at the bifurcations of the right main pulmonary artery. ECG shows sinus tachycardia with features of right ventricular strain. Echo shows dilated right ventricles with right ventricular dysfunction. Now, this is the ECG of the woman. If you are following the step-by-step analysis of an ECG, when you look at your lead 1, you can see a P wave preceding the PRS complex, meaning there is a sinus rhythm. But if you want to calculate the heart rate, it's looking like 3 big bursts, and if you divide it by 300, this is approximately 100. That means the patient is tachycardic. Now, it's tachycardic. When you now go ahead to look at the axis, the most equidistant here is lead 2. The one that is perpendicular to lead 2 is the AVL. And naturally, you know that AVL is a positive lead. Meaning, with this now, being a negative lead, you are going to track it down to the right side, meaning that this patient has a right axis deviation. If you go further and look at lead 1, V1 rather, naturally the QRS complex in V1 are negative, but this is positive. And if you look at the ratio of the S wave and the QRS complex here, there's a reversal here, and the amplitude of the R wave even in, okay, it's not up to 7, but there is a reversal. Is ratio of 1 R wave to S wave here is more than 1. Now, looking at all this, sinus tachycardia with features of right ventricular strain is in keeping with features of pulmonary embolism. We now did an echo for the same patient. If you look at it, I said naturally, the left side, which is the left ventricle, constitutes 2/3 of the ventricles, while the right ventricle constitutes just a 1/3 of the ventricle. But if you look at this patient, you can see that from this measurement, the right side at the right ventricular base is 5.0, while the LV is 3.0. If you do the ratio, you can see that this is more than 1. Now, we now look at the parasternal short axis of the patient. You can see a D-shaped sign because of the prior buildup on the right, giving the ventricle a D-shaped septum in diastole. Now, putting all these features together, what is the likely risk stage of the patient as at the time of presentations in cardiac care? A is low risk, B is intermediate high risk, C is high risk, D is intermediate low risk. Please, you can drop your answer. You can drop your answer in the chat box or the Q&A section. Okay. You can go up. Okay, maybe we'll come to this. Somebody is asking about how the nurse can help this patient arrive at the hospital. Okay, we'll come to that. Now, what is the likely risk score for this patient on presentation? If you look at this, we said initially that the probability risk score for this patient is 6. We did our bedside echo. It shows features of right ventricular dilatations and dysfunctions. We now did our cardiac biomarkers. Troponin was elevated. Don't forget that anybody that has a right ventricular dysfunctions with an elevated cardiac troponin is in the categories of intermediate high risk, compared to intermediate low risk, which is only right ventricular dysfunction, but the cardiac markers or the troponin is normal. The answer for here should be intermediate high risk is the answer for this patient at the time of presentation. Now, okay, this is just the recap for how we arrive at the answer for the patient that I've discussed earlier. I said about the ECG and echo of this patient, what is not correct? About the ECG and echo of the patient, which is not correct? ECG is in keeping with right axis and right bundle branch block. And I explained earlier, it has right axis deviations and incomplete right bundle branch block. That means this is correct. There is D-shaped septum on the echo. This is also true on the parasternal short axis because of the buildup of the pressure on the right side. It gives the left ventricle a D-shaped septum in diastole. Now, C, right ventricle is dilated. Based on the previous image that I showed, the right ventricle is dilated. No features of right ventricular overload. This one should be false because if there is no right ventricular overload, The right ventricle will not be dilated. The right ventricular wall will not be dysfunctions. That means the correct answer here, which is not correct, will be D in this scenario. Please, any questions so far? Okay, somebody dropped something. Okay. Okay. Now, the way the patient, the nurse can assist this patient on arrival, don't forget that
someone answered
somebody have answered. Okay.
Yeah, it's not an attempt.
Okay. The attempt to question 4 is actually D. We said right ventricle is dilated is the correct answer. Because if you go back to the image I showed earlier, look at this. So your right side is dilated compared to the left side, meaning that this one is actually dilated. It's part of the correct answer. No features of right ventricular overload is a false answer, because if there is no right ventricular overload, the right ventricle will not be dilated, and there won't be problem with right ventricular systolic functions. Okay. Let me go back to the Q&A section. Yes, the next intermediate iris was very correct. Intermediate iris was very correct. That's good. Now, the way the nurse can assist this patient before the arrival of the medical officer. This is a patient that is came in with desaturations. Patients that is having difficulty in breathing with some level of chest discomfort. Part of what the nurses will do as part of the initial resuscitation of this patient is to put this patient on bed and preferably, because of difficulty in breathing, in air-on positions, attach the cardiac monitor to look at the vitals and also to look at the risk of possible arrhythmias that this patient can develop. Because of the hypoxic pressure that is ongoing, patient can develop all sorts of cardiac arrhythmias in this scenario. Of note is that the patient must be commenced on a high flow oxygen to optimize the saturations to nothing less than 94–95% on UMIA. The response will determine the subsequent approach to the management of oxygenation in this patient. Now, the next thing here is now, while the patient was on admission in our center here, he was commenced on oxygen therapy via a non-rebreathable face mask at 15 liters per minute. He was initially commenced on subcutaneous cleansing, which is 80 milligrams 12 hourly. And while on admission, patients still remain desaturating. Saturation was still around 88%. It remained tachypneic. The initial blood pressure of 136/80 dropped to 100/60. This is almost 20/10 drop from the initial baseline BP, which is a pointer to an hemodynamic compromise. Now, based on what we've discussed so far, what will be your approach to treatment of this patient at this stage? Don't forget, initially when he came in, he was commenced on subcutaneous cleansing, and at the time, vitals started going down. What will be your approach to this patient? Also bearing in mind, this patient had surgery about 4 days ago. What do you think will be the approach to the management of this patient? To continue the subcutaneous cleansing, consider surgical embolectomy, systemic thrombolysis, catheter-directed thrombolysis. Please attempt, please. Chat box. Okay. High risk intermediate, what will be the approach to treatment? high risk, intermediate. Okay, for these patients, the answer will be between A and B. But don't forget, we said that this patient has surgery in the last 4 days. Systemic thrombolysis will be counterproductive in this patient because the patient is going to bleed in your hand, and you may even lose the patient. In this patient, what we did was catheter-directed thrombolysis, which is the best appropriate thing to do in this patient because B, correct. B is the correct answer. You introduce your catheter through the femoral artery, take it direct to the pulmonary artery area, and you start lysing gradually over hours. Now, this is a recap to what has been discussed about the management of high-risk patients, which is primarily a reperfusion therapy for high-risk patients. Supportive care like oxygen, fluid, usually cautious administrations of less than 500 ml of normal saline, vasopressors, and non-epinephrine were appropriate in the patient. Now, the patient had catheter-directed thrombolysis on day 3 of admission, and post-catheter-directed thrombolysis require less oxygen supplementation and saturating at 94% on room air. She was transited to oral anticoagulant, Ivaroxaban, which is 15 mg BD, that is to be taken for 21 days and subsequent daily for the next six months. And so it was canceled. Okay, we canceled about the duration of anticoagulation. Discharged on day 7 of admissions, and he has been on clinic follow-up. I still saw this woman about 3 weeks ago in the clinic. Okay, if you look at this for the case 2, on admission, look at the echo before the catheter-directed thrombolysis. And look at it after 72 hours of catheter-directed thrombolysis. You can see that the left side is now assuming its natural size, and the initial dilated RV has drastically reduced in this patient. That's the benefit of the systemic thrombolysis that this patient had, because it avoids this patient of this long-term complication from pulmonary hypertension that the patient will now develop right ventricular dysfunction, poor quality of life, and others, which is what we do very well in cardiac care. High-risk patients that you see in various centers can be referred for this place for an higher care of pulmonary embolism other than anticoagulation where required. This is case 3.
All right, so this patient presented to the hospital ER. She was a 69-year-old retired male professor, and came in with shortness of breath that got worse while on admission at the peripheral hospital. He also had cough, which was productive, and then he complained of chest discomfort, which was non-radiating to the arm or the neck, and he was also not a known hypertensive or diabetic. He neither smoked nor consumed alcohol. So initially, while at the peripheral center, he was managed for committed acquired pneumonia, and he also had an urgent CTPA done, which showed consolidation in the right lobe with filling defect of the right pulmonary artery. So on examination, it was an obvious respiratory distress. His pulse rate was 108 beats per minute, regular, good volume. Blood pressure was 140/78. He had no raised JVP. Heart sounds were normal S1 and S2, the loud P2. Respiratory rate was 30 cycles per minute. And oxygen saturation in room air was 89%. And on examination, he had bronchial breath sound with coarse crepitations and the right lower lung zones laterally.
Now, if you look at this particular patient, difficulty in breathing that got worse, meaning that either a new onset difficulty in breathing or a worsening of the baseline difficulty in breathing will raise a high index of suspicions in such a patient, especially in a patient that most likely has been on hospital admissions, hospital bed for more than 48 hours. Patient can develop a pulmonary embolism while on the hospital bed if a thromboprophylaxis was not commenced in a patient. Looking at the age of these patients, increased risk of PE from endothelial dysfunctions. Patient has been on bed for more than 4 hours, leading to immobilities. If we look at the trials of the pathophysiology of development of pulmonary embolisms, these patients are at risk of developing a PE. Though they are managing for pneumonia in the first instance, but the clinical condition got worse. Patient now started desaturating. Your index of suspicion here must go straight to pulmonary embolism on the background of probably community-acquired pneumonia that has been managed initially.
All right. So for the laboratory test, with the D-dimer, which was 4.5 milligram per liter, significant, and then full blood count showed total blood WBC count of 11.8 thousand, the neutrophil percentage of 76.2%, and his kidney function tests were unremarkable. NT-proBNP was slightly elevated at 544 picogram per mil. Troponin was normal. His INR was 1.0, and then his hemoglobin A1C was 5.7, which is okay. And CTPA, like he did, showed a filling defect at the bifurcation of the right main pulmonary artery. Okay. So this was the ECG. So from this ECG, we can see that the beat of
the pulse is tending towards tachycardia, yes. Around 98 or 99 beats per minute. Now, if you look at the axis here in these patients, the most equidistance here is looking like lead 1, and perpendicular to lead 1 is AVF. AVF is here is naturally supposed to be a positive deflection, but this is looking negative. That means you track it down to the opposite side. Okay, it's looking like normal axis at 90. Okay, but of note is when you look at your lead 1, no, V1, V2, V3 to V4. Okay, to 5 and 6, they have these T wave inversions on the precordialates. Usually you see it on V1, V2, V3, but in some instances it could be all the precordialates, which was the patient has. Now this is the echo. The right is at the base is still slightly dilated than the left ventricle, which is the reverse of the case. Now, what is the likely P severity index of the patient at the time of presentations at the hospital? 69-year-old man probably has been admitted for more than 48 hours, worsening difficulty in breathing. BP when he came in was normal. D-dimer was elevated. Troponin was normal. BNP elevated, and is tachycardic. What was the risk of this patient?
Your responses in the Q&A on the chat box, please.
Just to analyze, yes, our index of suspicion is actually pulmonary embolism. But one thing that you will look at is that this patient has a right ventricular dilatation, which is likely to be from the right ventricular strain. And if you look at our risk stratification tool that we projected earlier, a patient that has a right ventricular dilatation with a normal cardiac troponin, right ventricular dilatation, normal cardiac troponin, is intermediate risk. Is intermediate risk. But if you now want to get, you'll be a decision candidate, you want to stratify further, this is going to be intermediate low risk because the cardiac troponin is normal. Intermediate, yes, correct. Intermediate risk, B, correct. B, correct. Okay. Now, the answer here is B, actually. The answer is B. Now, what will be your approach to treatment at presentations of these patients? Your approach to treatment, don't forget, we said that low risk and intermediate high risk, you start with your anticoagulations. You now go further to stratify your intermediate risk to intermediate low risk and intermediate high risk. Intermediate high risk, your highs must be on there because the risk of PE-related mortality is very high. PE of poor clinical outcome, risk of poor clinical outcome, and the risk of deterioration within the few days of admissions is very, very high in them. But don't forget, we said this is intermediate low risk in these patients. Answer, please. A, high flow oxygen and systemic thrombolysis, catheter-directed thrombolysis, high flow oxygen and subacute enoxaparin at 1 mg per kg 12 hourly, surgical embolectomy. Answer? Surgical embolectomy. No acute. Okay, since it's intermediate low risk, the answer will still be give you oxygen and you commence your anticoagulation, which is subacute enoxaparin. Okay, while on admission in our hospital here, it was commenced on oxygen therapy via a non-repeatable mask at 15 liters per minute, and it had subacute enoxaparin at 80 mg 12 hourly. 7 hours to admission, patient saturation has improved to 90 to 96%, though the respiratory rate is coming down, that's around 18, and BP remains stable. What approach
to the long-term treatment for patient is
not correct?
Yes, what transitioning
from hospital admission to want to discharge home, yes. Which one is not correct? If about 15 mg BD, then 20 mg daily for 3 to 6 months. If about 20 mg BD, then 20 mg daily for 6 months. 10 mg BD and then 15 mg daily for 3 to 6 months. 15 mg BD and then 20 mg BD for 1 month. Okay, attempts. I'm not sure which A or C. Okay, I'm not sure. Okay, but as if the first person that attempts seems correct, I guess it's this question 8A. Question 8 is actually rivaroxaban 15 mg, 21 days as a loading dose, and then 20 mg daily for 3 to 6 months.
Which is correct.
Which is not correct.
Okay,
no, it's supposed to be, sorry. This is supposed to be which is correct.
Yes.
There's a mistake here.
Sorry.
Yes. It's supposed to be which is correct. Please. Question 8, which is correct as the long-term management treatment approach in this patient? Which is correct? It should be rivaroxaban 15 mg BD and then 20 mg daily for 3 to 6 months. Okay. It was transited to oral anticoagulant at day 6, 20 mg BD, and then 20 mg daily, and cancel the expected duration of anticoagulation of 3 to 6 months. Discharge on 8th day of admission and has been on clinic follow-up. This is the echo at 2 months. Compared to 4.8 initially, is now 3.4. Okay.
So in conclusion, and this is the take-home message here, in the management of the high index of suspicion is very, very crucial because it is something that it can occur commonly, but it's often missed. So you must suspect it in patients who present with unexplained dyspnea and desaturation. You've seen this patient breathless, SpO2 is it's tanking 80-something%, you have a higher index of suspicion that this could be pulmonary embolism. And you need to act fast because patients who come with pulmonary embolism and are hemodynamically unstable, it is very, very high risk, and then they require immediate reperfusion therapy. The gold standard for investigation for diagnosis is the CTPA. Echo is crucial for those who are unstable. And the therapy is still the NOACs, which is what we use as the standard ones for patients. That's what we use for most patients now who are stable.
Now, as additionally, that in cardiac care multi-specialist hospital, thrombolytic agents are readily available for those patients that require thrombolysis, either for PE and other reasons, patients with strokes. We also do a catheter-directed thrombolysis, in which a patient will be taken to a cath lab in those ones that are high risk, that will assist in the solutions of the clots that are formed with an accompanying improvement in hemodynamic status, the saturations, and the right ventricular functions. We appreciate everybody that's made it a call to join this the monthly webinar at the Cardiac Care Multi-Specialist Hospital. We appreciate you all. We don't mind if there are questions or clarifications. Thanks for joining us.
Thank you very much.
Okay. There are some questions in the chat box in the Q&A section. Okay, it rose to 19, just like that. Okay. Thank you, sir, for the presentation. During my internal medicine posting, we managed a patient with suspected myocardial infarction while also trying to rule out pulmonary embolism, and morphine was administered. My question is, since morphine has historically been used in both conditions, but does not reliably differentiate between them and is now subject to clinical questions, what is the current rules? What is the current rule in such scenario? Okay, if I get this question very well. Okay, is it for the management of the chest pain is wanted to clarify as well? Okay, yes, it's a drug that is well controlled, but we still use it very well in cardiac care here. Patient coming with MI that is having serious chest pain, patient with pulmonary embolism. Don't forget that apart from the analgesic benefits of morphine, it has other benefits in terms of allaying patient anxieties and all those. And that's why it still remains the first line in those patients that has myocardial infarctions and in patients with pulmonary embolism where required. Now, the second one is regarding direct oral anticoagulant, which often are preferred as first line. Should treatment be initiated with a higher loading dose or a lower starting dose and query durations? Now, it depends on which of the NOACs that we are using. But for the rivaroxaban, usually what we do is we start with a dose of 15 milligram BD, which if you sum it up, that's 30 milligram in a day. That's more of a higher dose, which is a form of loading dose for 21 days, 15 milligram BD. You now take it to 20 milligram daily. But if it's for apixaban, apixaban is given at 10 milligram BD for a week before we now taper it down to 5 milligram BD. It depends on which one that you are using to determine the initial dose. But in terms of duration, commonly we do 6 months, though the guidelines recommend 3 to 6 months, especially if you can identify the predisposition to development of pulmonary deep venous thrombosis, you can go for 3 months. But in those ones that probably you cannot really identify the risk factors, you go further for an additional 3 months, usually 6 months in such a patient. But we usually do 6 months, but the recommendation is treat for 3 to 6 months in such a patient. My chat box is disabled for me to contribute with my own answer. Maybe the question is not the crowd. I don't understand.
She did, yeah, this is Q&A.
Okay, there are 3 incorrect.
Yes, that was
okay. We corrected. I was sorry for that.
Yes.
Okay. Last question, I didn't get the answer. Is the correct answer that we are looking for, and that is the A that is the option. Thank you very much. Please, how can we get the recorded section? The recorded session will be sent by the public relation unit of the hospital. In as much as you register with your email address, that will be forwarded to you. Yes, on Monday. Thank you.
Please remember our health walk tomorrow, please, by 7 a.m. You can come out. It's at CBD. You can come out and participate. Thank you very much.
Thank you, and God bless.
God bless you.